Good afternoon, everybody. Welcome to the Department of Medicine Grand Rounds. This week's Grand Rounds is part of a professorship lectures in the Division of Endocrinology, Diabetes, and Metabolism. It alternates with the Fishman Lecture one year, and the next year is the Schuyler Lecture. This year, it's the year of the fish. And so Dr. Fishman, who many of you may not have known in the audience, but was an illustrious figure here at the University of Miami, who I had the good fortune to know. He was here on faculty for over 40 years, actually 41 to be exact, and he was still very active in the Division of Endocrinology, Diabetes, and Metabolism until 2008 when he retired, and then when he passed away in 2021, he was still active, coming to Grand Rounds and involved in the division. We're very grateful for the philanthropy of his former fellows, specifically a Dr. Weiss, no relationship, who was one of his fellows who is sponsoring today's lecture. Just to let you know a little bit about Dr. Fishman, he was an endocrine fellow at Vanderbilt under Dr. Little, and those of you that know anything about the pituitary or the adrenal gland know Dr. Little was the little test for diagnosing hypercortisolism. And Dr. Fishman himself, while working with Dr. Little, was very instrumental in allowing us to understand the pathophysiology of primary hyperaldosteronism. Over the years, Dr. Fishman was chief of the Division of Endocrinology here at the University of Miami, as well as chief of endocrinology at the VA, and has been a real role model as an academic physician and bridging the gaps between the VA and the University of Miami. He was also instrumental in developing the very first HIV/AIDS Combined Institute. Far cry from endocrinology, but just goes to show you the type of visionary individual that he was. And it's our pleasure today to let me allow the chief resident to come up and to introduce our real world-class endocrinologist who's going to be introduced now.
Hi, everyone. My name is Mariana Velasquez. I'm one of the Internal Medicine Jackson Chief Medical Resident, and it's my pleasure to introduce today Dr. Civitelli. He's a professor of medicine at Washington University in St. Louis, Missouri. He's hailing from Siena, Italy. He has been affiliated with the Division of Bone and Mineral Diseases since 1985, serving as a division chief for 15 years. He's shaping his trajectory as a leading skeletal research, education, and patient care center. As a physician scientist, he has published over 200 original articles, reviews, and book chapters, and leads a dynamic bone biology program supported by the NIH for the last 30 years. As a clinician, Dr. Civitelli provides specialized treatment for patients with metabolic bone disorders. He has held leadership positions in the American Society for Bone and Mineral Research organization, including president and other international professional organizations. He also has served as an editor-in-chief of Calcified Tissue International and the Journal of Bone and Mineral Research. His contribution as a researcher and as a mentor have been acknowledged by prestigious awards, including the 2023 Gideon Rodan Excellent Mentorship by the American Society for Bone and Mineral Research. Please join me to welcome Dr. Civitelli.
Thank you so much for that nice introduction. Welcome everybody. It's actually an honor to be here. I've been visiting the University of Miami probably 15 or 20 years ago, I don't remember, but I'm really fun to come back. Also because one of our physician current faculty, Dr. Mosani, was trained here as an endocrinologist and then moved to our center where she has become one of the board experts. So also grateful to Dr. Bernal for his invitation. It was very kind, and I'm happy to tour and meet with you in the next 48 hours. So today we're going to talk about osteoporosis, of course. This is the topic, the major disease that we deal with in our division. Our division in WashU is peculiar because it's really specialized in bone and mineral disorders. Most of us are endocrinologists by training, but we also have a faculty now who, with a different background, geriatrics, rheumatology, and also primary care most of osteoporosis patients see their primary care physician first. In fact, primary care physician is the first to see the osteoporosis patient in many cases. So it's become a sort of a more interdisciplinary, cross-disciplinary area. And we have a large clinical program now seeing patients over 3 different sites. But today I wanted to discuss with you primarily the current challenges that we are facing with these patients at high risk of fracture and discuss with you options. So these are my disclosures, not much to do with what we're talking about, except, investment for long-term planning, essentially. So the objective today is to understand the impact of osteoporotic fractures on health, how to identify subjects at risk, how to manage them, and understand the benefits, but also limitations of current options. So as you know, osteoporosis is defined as a skeletal disorder that is characterized by decreased bone density, but primarily decreased bone strength that predisposes a patient to increased risk of fractures. And it is still a major public health problem. These are all data taken from the Surgeon General's report. It was published 20 years ago now. But just to give you an idea, the numbers now are far greater than this. But just as a rule of thumb, the lifetime risk of fracture is 50% for women, meaning that any woman at age 50 today has a 50% chance of getting a fragility fracture in the rest of their life. And this is 1 to 5, 20 to 25% for men. So it is a big problem affecting a lot of people. And you can see here, most of the fractures are vertebrae, wrist, and hip. And primarily it's the hip fractures that really impact life. These fractures, which we like to call low trauma fragility fractures, can result from typically fall from a standing height or less, or just in the absence of trauma. And particularly in the case of hip fracture, that changes life. It's just, it's especially in the elderly, it's really a life-changing event. And in fact, about 10 to 20% of people who have a hip fracture die within the first year of the fracture. Not directly because of the trauma, of course, but because of the consequence on their life and the morbidity associated with it. And 10% of those will have another fracture. Up to 25% of patients with a hip fracture will require long-term assistance. They will never regain full independence. So the numbers are pretty high, and the costs are exorbitant. And the estimate is that the cost may even triple by the year 2040. We are not far away from there, by the way, but this just configures the problem as it is, not just as a specialty disorder, but as a real public health problem. The other concept that sometimes that we don't really take into sufficient consideration is that once somebody has had a fracture, a fragility fracture, the likelihood of a second fracture increases 5-fold. And in fact, a lot of people, the fracture have already had a fracture before. So this is a very simple case here, just to bring the conversation down to practicalities. Unfortunately, it doesn't show very well here, but the arrows there point to comminuted, non-displaced fracture of the distal radius. This occurred in a 63-year-old woman with no significant history after tripping over a rug at home. Okay, that's really a typical situation of fragility wrist fracture, tripping on something at home, domestic accidents. She had no previous fractures, takes no medications, consumes some servings of dairies, takes some vitamin D supplementation, no additional lifestyle risk of factors, risk of fractures, and no family history. Her weight is a little low, 120, which puts her under the so-called threshold for people with thinner bones, which is approximately 125, 128 pounds. So that's the only factor. So the question is, what should we do next with this individual? Should she undergo bone density test first to determine if she has osteoporosis? Because we don't know. She just presents with this fracture. Or does she already meet the criteria for osteoporosis, having had a fracture? And we would then do a bone density test to determine the severity of the disease and decide whether active treatment is appropriate. Or should we get a spine X-ray to see if there are additional compression fractures before making any additional decisions? Or should we consider this fracture as an event of life and just send her home with no further testing and say, be more careful next time? What do you think? A, B? B? The majority is for B. And in fact, this is the correct approach. The patient already meets the definition of osteoporosis because she had a low tonal fracture. This is a very minute fracture. Sometimes are far worse than this, but just to bring up the attention that somebody with that particular event, even if the bone density is unknown, or even if bone density is not showing osteoporosis, does meet the definition of osteoporosis. And therefore, it's important to do bone density to determine the baseline, essentially, on which we'll base additional recommendations. But the patient does have osteoporosis, and we need to act upon that. And the first thing that we do for everybody, even regardless of bone density, is provide some universal recommendations. There are a lot of environmental factors or lifestyle factors that can be corrected right off the bat without even before getting more in depth. Advice for proper calcium and vitamin D intake, and I'll say a few words about that in a second. Straighten up your life. Reduce or discontinue tobacco use if that's a problem, or excessive alcohol intake. And more importantly, weight-bearing exercise. I find this is the most common hurdle. People don't like to walk or to mobilize nowadays. Unfortunately, that's a barrier that we need to address. We recommend at least 30 minutes of walking 3 days a week, although the field is now moving to recommend even more active exercise, putting more weight on your bones. So weight training is something that we recommend now. And for fall prevention, this applies primarily to more elderly people who live in a less supervised environment. Remove loose rugs, so would probably save the fracture to this patient. And of course, physical therapy for core strengthening. It's good. So these are all the universal recommendations that you will never wrong in applying to everybody. Calcium and vitamin D. This is a topic that can generate a lot of controversy in the field. Some of you have probably read so many reports about vitamin D, how much would you recommend, 1,000, 500, what's the level of vitamin D in the circulation that we should target. So, but in general, I think the whole point can be really distilled into a few, 2 or 3 bullet points. Calcium. If you target about 1,200 to 500 milligrams per day, which, by the way, includes the calcium that comes from the diet, and for some people who are very health conscious, that could be a substantial amount of the total daily requirement. In fact, some patients ask me, can I do without supplements? And the answer is yes, you could. You have to, to be very conscious about what you eat, though, and make sure that there is enough calcium there. It can be done, but it does require a little bit of attention. So it's easier to just recommend 1 tablet of calcium per day. Vitamin D, we recommend between 800 and 1,000 units per day. recommendations of the Institute of Medicine are lower than that. But I think if you go between 100 and 1,000, there is no danger of overdoing it. In fact, many people probably require more than that. We use the larger doses and the classic ergocalciferol preparation of 50,000 units just for the cases where we need to booster and replenish a deficiency. Usually, the common recommendation is to use 50,000 units a week for 6 to 8 weeks. I think it does make sense to space the high doses because there are some data out there suggesting that massive doses of vitamin D taken altogether may actually be counterproductive. So it's pretty easy to do this. And then adjust the doses based upon serum 25-hydroxy-D. So here in this bar chart here, I try to clarify what we intend for insufficiency, deficiency, and toxicity based upon a scale that we keep in our, in our clinic, but sometimes it can be adjusted. I think it's fair to say that between 20 and 30 nanograms per ml of 25-hydroxy-D, it's probably, it's not deficiency, but I think we can do better than that because studies have shown that some people in that range can still have deficient mineralization on bone biopsy. So there is no reason to be stingy, I think. Why don't we just go above 30 and make sure that there is everybody is provided with the right amount. The upper limit, it's 90 here. Now it's actually being brought down to 80 depending on the laboratory limits. But that's also to avoid because too much vitamin D can cause too much calcium absorption and not much kidney stone, but nephrocalcinosis, which is far worse. That's a reversible problem. So this is the vitamin D story. Bone density. Dex has been with us for almost 3 decades now. And one of the limitations in our field is that there has been no technological advance here, despite all attempts. But bone density by DEXA, which is a very simple X-ray based absorptiometric technique, has helped us greatly identify patients who are at risk of fracture and still serve us pretty well. Now it's you can find these devices in larger centers. They're no longer present in primary care or OB/GYN offices because it's difficult to make ends meet with the current level of reimbursement. But it is still the key method to estimate fracture risk. As you know, bone density is expressed at T-scores, which is the deviation of your patient from the, oops, sorry. I was pointing to, I'm sorry. I'm just going to go with the mouse here. So the T-score is what we are looking at. The T-score is actually the number of standard deviations that your patient has relative to the maximum ideal peak bone mass, which is achieved at around age 30. The Z-score instead represents the age-adjusted, that also sex-adjusted deviation from after normalization for age and sex. So the reason why we use the T-score is because no matter how you get to your level of bone density today, what's important is whether the amount of bone that you have today is able to withstand the weight and the challenges of daily life. So that's why it's a T-score. And women, indication for bone density are now, that's I think pretty well standardized. There are, if you go in the literature, you find different guidelines with different by different professional organizations. Here I merged the NOF and the American Academy of Family Physicians, but the ACE also has their own guidelines. But right now there is an effort by the ASBMR in trying to pull things together and make a more standardized universal set of recommendations instead of having to look at so different recommendations. But really, what boils down to is that 4 or 5 points that on which everybody agrees. Any woman above 65 postmenopausal and men over 70 should undergo bone density testing. Younger women, of course, or men should undergo testing if there are other risk factors, and of course, somebody with a fracture after age 50, just like the case I presented before, and if there are any other conditions that are known to be associated with increased fracture risk and low bone density, rheumatoid arthritis, treatment with glucocorticoids, and now treatment with endocrine therapy for cancer survivors, primarily breast cancer and prostate cancer, on aromatase inhibitors or androgen deprivation therapy. It's actually growing share of the population. We see a lot of referrals from the oncologists for that. So once you have your test, your T-score, what you do with it? Well, if your T-score is below -2.5 threshold, it's easy because the patient has osteoporosis, and then it can be a candidate for treatment. And of course, if there is a clinical diagnosis of a fracture, just like in our patients, it's also easy. The question is what to do when the T-score is between -1.0 and -2.5, because that puts the patient in the range of that we call osteopenia, sort of a gray area. Of course, somebody with the bone density in the normal range, you may think about, maybe just follow. Let's see if we can adjust your lifestyle, and maybe come back in 1 year or 2 years. Let's check again and see how things are going. But in the gray area between -1 and -2.5, how do we make decisions? Here is when these tools that estimate fracture risk come to the rescue. The most used is the FRAX calculator. FRAX is actually a proprietary name. It's been developed by colleagues at the University of Sheffield in the UK. It is not endorsed by WHO, by the way. That's a common misunderstanding. It was published during a conference where Sheffield was part of a WHO program, but it's not endorsed by WHO. It's a proprietary algorithm, but it's now part of all the guidelines. So we use that. It's pretty easy. And you can calculate the fracture risk from bone density and other non-bone density related factors. And these are the thresholds here that we use. Arbitrary thresholds, of course, but still useful, just like the T-score, to help us make a decision. So more than 3% for hip fractures, more than 10% for major osteoporotic fractures, including everything, are sufficient to recommend therapy. And this is the FRAX. For those of you who are more attuned to this area, they will know that there is also an upgrade to the FRAX. It's called FRAX Plus, which includes also some factors that are not included here. For example, length of treatment and cumulative dose of glucocorticoids, severity of diabetes. Diabetes here is not included at all, even though we know that diabetes does represent an additional independent factor of risk for decreased bone strength in itself. So FRAX Plus is better, but unfortunately it's not free. You have to pay €1 for each test that you do. So it's just that's what it is. It's a proprietary system. But the original FRAX is still free and very helpful. So this is typical result. This was probably the same patient as I mentioned before, and for her, the risk of major osteoporotic fracture is 11 and 2% for hip fracture. So she doesn't really meet quite the criteria. So we could tell her, if this were only the base of if she hadn't had a fracture, we could tell her, maybe come back, okay? But she did have a fracture. So, okay, so this is the case of that patient. She did have a previous fracture. So as you can see here, the risk calculation changes substantially. Now, the risk of major osteoporotic fracture is 19%, almost close to the threshold, but the risk of hip fracture is 3.5%. So that changes completely. And again, validates the idea that if somebody has a fracture, already has a problem, it should be addressed as a patient with osteoporosis. And the FRAX can also be modified by other factors, of course. You can see the difference that being on glucocorticoid make, and also age itself. So this is a patient of 68, 5 years older with the same bone density, but the risk is different. So when somebody comes to you and tells you, you know, my doctor told me that I have the bones of an 80-year-old. No, you don't. If you're 63, you have the bones of a 63-year-old. And because the same level of bone density at 63 has a far lower risk of fracture than at 80. Okay, so there are many other factors that need to be considered. And now we have started using this additional parameter, so-called the trabecular bone score, that is, again, a proprietary algorithm that takes into account, based on the DEXA images, the structure of the bone, try to define, you know, how the bone is organized in space, struts, rods, plates, and so forth. It gives this parameter that it does help us in many cases, but I have to say that's not really, that's not been a game changer. And we have some problems also in interpreting data when we repeat the measurement. I don't think it's ready for prime time to help us estimate the effectiveness of therapy. That's useful in some cases. So moving on to more, you know, therapy-oriented. Any questions, by the way, at this point? Any clarifications? Any? So in terms of treatment of osteoporosis, it's very important, actually it's fundamental to understand the bone remodeling process, because any medication that will interfere with bone density, they have to interfere with the bone remodeling process at some point. So this is a system that essentially defines a sequence of events that occurs throughout a lifetime in the so-called bone remodeling unit. So if you look at bone in certain areas on the surface, you'll find some specific areas where cells are actively remodeling. And this is important to not just during growth, but also throughout a lifetime to repair old fractures, microcracks, fractures, but also to replace old bone with new bone. The process starts with activation of osteoclasts, which can occur in different ways. And this phase called resorption lasts just for a few days. Once the osteoclasts have left this resorption lacuna, osteoblasts are activated, again, through different mechanisms. And these bone-forming cells then starts working, deposit the new bone, which at the end of the remodeling cycle, in theory, replace completely what's been lost. So any changes in this balance between resorption and formation can lead to a negative or positive outcome in terms of bone density in each bone remodeling unit. Now, these are microscopic units, but if you multiply this quanta of bone remodeling by the millions of remodeling units that are active throughout the skeleton at a single time, you can see how changes in bone density can occur actually even fast. So the whole process lasts 3 months. And of course, based on that, we have essentially 2 major strategies for interfering with it. One is to inhibit the osteoclasts. Okay, that's the easiest thing. In pharmacology, it's far easier to inhibit a process than to stimulate. And that's what we've been doing for many years. All bisphosphonates, rank ligand inhibitors, and calcitonin, and estrogen are all inhibitors of bone resorption. There are what we call anabolic agents. In bone, anabolic means stimulating bone formation. And essentially, there are 2 that are purely anabolic, teriparatide and abaloparatide. They're both PTH analogs. But in the last few years, we also started using sclerostin inhibitors that cannot really be included in either one of these 2 categories because they're bifunctional. They both stimulate bone formation, but also inhibit bone resorption. So I call them bifunctional. So we look at how best we can use these agents, and also new thoughts about how we can use them in combination or sequential treatment. The first real game changer, I would say, in this field had been alendronate, oral bisphosphonate, which was introduced in the market in 1995. Before then, we only had estrogen and calcitonin, which really didn't work very well. So alendronate really has been the game changer. It's changed the outlook of the osteoporosis therapy. Now we had an agent that actually reduced fracture risk. This is a historical slide from the first phase 3 trial from fracture prevention. And you can see that you can expect a substantial increase in bone density in patients who are naive. And the point I was going to make is that, if you stop the treatment here, 60 months, and let the patients go without treatment, things don't change very much. So you end up with a stable bone density. So we thought with this experience, we thought, we are safe. We can, pick and choose all the medications we have. We treat for a few years and then the patient goes. Unfortunately, the reality is a little bit different. And the reason why bone density is probably stable for a long time with the bisphosphonates, even now they're given, as you know, weekly, monthly, even once a year in the case of reclass, zoledronic acid, once a year, IV, is because bisphosphonates are very similar in structure to pyrophosphate, which is a key element in the formation of the hydroxyapatite. Okay, without going into the details of mineralization, but bisphosphonate can be integrated into the mineral and then stay in the bone for a long time until they are released again through a next phase of bone remodeling. So for bisphosphonate, the bone represents a natural reservoir. That's one reason why they work for such a long time. Now, the other agents that have come later work differently. Case in point, denosumab, RANK ligand inhibitor. This was the first biologic to be introduced. This is a monoclonal antibody, fully human, that specifically binds RANK ligand. RANK ligand being a cytokine produced by osteoblasts and osteocytes that's absolutely necessary to make osteoclasts. So the antibody essentially binds the RANK ligand and prevents osteoclast formation and also activity. Very clean surgical strike. Okay, and it works wonderfully. Very little side effects because RANK ligand is really not produced very much else. So, and in fact, this results in reduction of fracture risk, even after 1 year. Now, as you know, denosumab is given at a dose of 60 milligrams every 6 months by intramuscular injection, so it's even easier to implement from a patient standpoint. And just 2 injections reduce fracture risk by more than 50%, and the effect is continued. Wonderful. So the problem is that what to do next? Okay, so when the patient has been on for a few years, can we discontinue and hope that things will stabilize? Unfortunately, no. So this is the first study that demonstrated what we now call the rebound in bone turnover after denosumab discontinuation. Okay, so here we are looking at serum CTX, bone resorption parameter, and P1NP, bone formation marker, and they both go up, and sharply so, once patients who have been on denosumab for 2 years are taken off. So a major issue, and this really, now we know, results in increased fracture risk. There are a number of papers showing that. This, I think, is the most clear one, was published a few years ago. This is actually taken from the phase 3 trial on fracture prevention and the extension, which some patients chose to continue with denosumab, others chose to stop. And those who stopped, seen here in the gray bar, their fracture rate went back to baseline. Okay, and also for multiple fractures. So just 1 year off denosumab brings back the fracture risk to baseline. So it's a problem. So the first approach was to give the most potent anti-resorptive we have, because because of the spike in CTX, we thought, well, if we prevent that, we'll prevent the rebound. Not so easy, unfortunately. So you can find several studies on this area, but I'm going to show you which I think is probably the most relevant one. This is a study from our colleagues in Denmark. Bente Langdal is her group. She actually designed a very complicated study in which she gave one dose of zoledronic acid to patients coming off denosumab, and she gave it at different times, either 6 months after the last dose or 9 months after the last dose. And then she left one group observation. So as you can see here, a dose of the zoledronic acid does decrease bone resorption. Okay, so this is patients given after 6 months. This is the decrease if you wait after 9 months. But in the patients who were left alone, they had to give a dose of zoledronic acid after 12 months because they were just losing too much bone. Okay. Unfortunately, although things may seem positive for those who were treated early, at the end of the day, I should say at the end of the year, and 1 year later, nothing worked. You see the same decrease of bone density as you see in those who are being left alone or given just one dose 12 months later. And that's a problem. So we know that we cannot really rely upon zoledronic acid to resolve this problem. So 2 years ago, the ACTS, the European Calcified Tissue Society, issued these guidelines, which are not too helpful in my view, because essentially it tells us to how to use denosumab. Okay, and that you should use it as less as possible. So in patients who need it, try to use it for only 12, 40, 24 months when the rebound is not as severe. But for the rest, really we have no solution, essentially, except to continue with denosumab for up to 10 years. But eventually we'll reach the point, and the problem will present again. So let me show you some additional data. This is from the group at MGH, Subhash Ramanchand and Ben Leader. They've looked at using alendronate or raloxifene after denosumab. And as you can see here, so these patients were treated only for 1 year, so it's a short term. But as you can see, a weak anti-resorptive, as is raloxifene, is not able to prevent the rebound in CTX and P1AP. Alendronate does seem to prevent. Is it effective at preventing bone loss? It looks like it is, but the raloxifene is not. So for patients who have been on denosumab for 1 or 2 years, you can use oral bisphosphonate to prevent a rebound. So that's good news. But we still have the issue of what to do with those patients who have been for longer than just 2 years. So let me speculate a little bit, okay? Because I think this particular problem, that's one of the major challenges right now in the clinic, has sparkled a lot of thought and research on what might be happening at the cellular level. Why do we see this huge rebound? So one thought is that if we use a reversible inhibitor of osteoclasts like denosumab, and by the way, a similar phenomenon occurs also for other reversible inhibitors. One case in point is the unfortunately failed cathepsin K inhibitor called odanarcatinib, which was developed by Merck and reached all the way to complete phase 3 trials and then was stopped because of fear of side effects of cardiovascular system. So even in that case, the patients who were enrolled in the study who chose to stop the medication So this huge rebound, just like for the denosumab discontinuation. So if you use a reversible inhibitor of osteoclast, what you're doing is to actually put a brake to the osteoclastogenesis. And usually this system, just like in an endocrine system, if you have a resistance, what you see is a buildup, the pressure up front, upstream. And here is a buildup of osteoclast precursors. So once you release the brake, then you have huge numbers of osteoclasts, and all in a sudden become active. But this does not explain why inhibiting osteoclasts does not work. So there must be some other explanations. And one speculation is that it's not just the osteoclast, it's also an osteoblast problem. So once you inhibit the bone resorption for such powerfully and for such a long time, 3-4 years, what you end up with is almost like a dead bone. There are no osteoclasts, but there are no osteoblasts either. And that's been proven with the bone biopsies in the phase 3 fracture prevention trial. So patients with denosumab have very little osteoblasts, only lining cells. So once you stop the inhibition, yes, you have these osteoclasts have now suddenly become active, but you don't have enough osteoblasts to restart the bone formation process. It takes a long time before osteoblasts precursor can be recruited and can undergo the differentiation process and work to form bone. Bone formation, as I mentioned before, takes weeks, months. Bone resorption takes days. So there is a different time gap between the two processes. And without osteoblast there or early osteocytes, there is very little production of OPG, which is a natural anti-rank ligand cytokine. So one hope is that we could prevent this rebound by a combination of anti-resorptive, but also bone formation stimulators. And I'll give you an example, a couple of examples. So going back to denosumab and discontinuation, it is safe to use for at least 10 years. But it's very important that your patient understands that they should stick to the schedule. Okay, so it's very important to monitor. And those who discontinue should be rapidly transitioned to something else. Oral bisphosphonates seem to be better than zoledronic acid, at least for those who have been exposed to denosumab for a short time. And romosozumab could be a good option. We'll go back on this later. So let's move to the anabolics. Okay, both teriparatide and abaloparatide, as you know, they are very similar compounds. Teriparatide is an analog of PTH. It's actually the natural PTH sequence, the first 34 amino acids. Abaloparatide is a design peptide, which is based on the PTH-RP backbone, but it's just equally active on the receptor. So they're both very similar agents. They both stimulate, they both works through activation of the PTH receptor. And they both increase bone density. Here, this is the study on abaloparatide, which also had the teriparatide arm, conveniently, so we can see the two at work in the same setting. Vertebral fracture prevention, of course, is very significant for both after 2 years of treatment. And there was some little signal in major osteoporotic fracture to suggest that abaloparatide might be slightly more effective. That's probably certainly that's the data. Although practically not so sure if really there is always an advantage. One of the advantages of teriparatide is that we can now use it beyond the 2-year limit. The FDA has lifted the black box warning about possible carcinogenesis, increased risk of osteosarcoma. That has not emerged after 15 years of post-marketed surveillance, so there is no more black box. And teriparatide can be used for as long as you think it's appropriate. Unfortunately, because of the way the labeling works at FDA, Abalo still has the black box warning, but I think will probably be lifted later on. Anyways, there are two very effective compounds. And this brings me to discuss about this anabolic window. So why do these PTH analogs work? Well, that's because at these doses intermittently, they stimulate bone formation more than bone resorption. Activating the PTH receptor ultimately does lead to activation of bone resorption because that's what PTH does. But in this peculiar low-dose intermittent administration, the activation of bone formation is greater than bone resorption. So if you look at this idealized picture here, where the y-axis is bone turnover, okay, bone formation in violet and bone resorption in gray. Over a period of time, the bone formation markers will raise faster than bone resorption, although at the end of a few months, the process rebalances. But you have this area here, which we call the anabolic window, in which we have a positive bone turnover balance. And that's where the balance is positive. So more bone can be added. The obvious question that was asked many years ago is that, can we widen this window by taking down bone resorption? So can we do a combination therapy, PTH analogs and bone resorption inhibitors? This was what has been tried, and I think the pivotal data were published about 10 years ago by Ben Leader at MGH, where he used teriparatide and denosumab either in combination, green, or in a sequence, and looking at teriparatide first and then denosumab, or the other way around. So if you look at bone density changes to the lumbar spine and also the total hip, the combination is the best in terms of bone density gains, proving that in fact the combination is probably efficient in widening the anabolic window. But then if you look at the teri to denosumab sequential treatment, at the end of the 4 years, there was really no difference compared to the combination. Yes, maybe more bone density gain at proximal femur, but not that much. So this, makes 2 points. First, yes, you can achieve larger gains by a combination of teriparatide and antiresorptive, but over the time of, over a long time, say 4 years or 5, you can achieve the same result with a simple sequential treatment. So that's why we don't do combination. We do a sequential treatment. The other point that comes from here is that the reversal combination, start with denosumab and then moving to teriparatide, is not as effective, particularly on the total hip. And as you can see here, there is an initial loss. However, with time, the anabolic effect of teriparatide prevails. So what does this tell us about denosumab discontinuation? Well, yeah, you could probably use teriparatide, but be careful because in the first in the first 6 to 8 months, bone turnover will go sky high, primarily bone resorption. So that creates a situation of very high bone turnover, and the effect on fracture risk is unpredictable. So I would not recommend this type of sequential therapy unless really there is good reason for it. Okay, and this is changes in bone turnover markers following the predictable changes. So you can see there is a 200% increase in citellopeptide with the denosumab to teriparatide switch. So the next question is, can we achieve the same using a single product? Can we have both an anabolic window and inhibition of bone turnover with the same compound? This is what the anti-sclerostin approach is doing, okay? And this is what romosozumab does. Romosozumab is, again, another monoclonal antibody, this time targeting sclerostin, which is almost, not quite, but almost bone-specific modulator of Wnt signaling. And without going into much detail, sclerostin is a very key component into this signaling pathway that regulates bone formation. And there are genetic disorders that prove that lack of sclerostin is associated with increased bone mass. So this is the theory. What's the practice? So that was a powerful, okay, powerful result, yes. Shall I try to turn on the microphone? Oh, okay. Okay. Okay, how about now? Okay. Okay. I hope they can still hear me on Zoom. Okay. All right.
We hear you
Okay.
on.
Great, great. Okay, so what I was going to say is that romosozumab does, in fact, show this biphasic bifunctional effect. If you look at the effect of a single injection of romosozumab, you'll see both a very rapid rise in bone formation markers, almost doubling within really hours, and that lasts for a long time. And then, upon monthly dosing of romosozumab, the effect continues for 3 months, but then it kind of wanes and it goes back to baseline, in fact, below baseline at 12 months, despite this continuous treatment. You do see this 50% reduction in bone resorption as well, but even that one wanes a little bit. And in fact, at the end of 12 months, continuous treatment with romosozumab becomes a weak inhibitor of bone turnover. So the key is really this initial large anabolic window where you have, the opening of an opportunity for a positive balance by modifying both resorption and formation. So this results in large changes in, let's see if I can move, in bone density at the spine, far larger than can be achieved with teriparatide, of course, or with alendronate, and positive changes at the femoral site as well. In my experience, it's true. It's very hard to see changes in bone density at the proximal femur with anything, except with romosozumab. The changes are not as large as in the spine, but they're typically positive. So this compound has actually changed the way we treat osteoporosis now. And of course, this is associated with a sharp decrease in fracture rates, even within 1 year of treatment, because romosozumab is approved for using for 12 months only, and then it has to be followed by something else. But even if you look at what happens 2 years out of the first year treatment, fracture risk is still reduced. So can we use romosozumab to prevent the rebound of bone loss and increased fracture risk on denosumab discontinuation? This is a study that was recently published by our colleagues in Seoul, Korea, Yumi Ri and her group. And they treated about 80 plus patients who have been on denosumab for a median of 4 injections with either denosumab or romosozumab for 1 year. So some of them continued with the denosumab, others were switched. And what they saw is that, yes, with the transition to romosozumab, you can not only prevent completely the rebound, but actually you can achieve a slight further anabolic effect. This is not clear on the proximal femur, but certainly you don't see the drop-off that we are accustomed to see on denosumab discontinuation. So this proves that if you want to transition somebody off denosumab, who has been on Prolia for 5, 6, 7, 10 years, romosozumab is a good option. The only barrier is getting approved by the insurance company because it's expensive. But that's a very good option. And in fact, it does work. Of course, you have also to deal with the problem of rebound after romosozumab discontinuation, which being the antibody a fully reversible inhibitor of bone resorption also carries, as shown here. Okay, so this is a phase 2 trial, but it's clearly showing that if you stop treatment, bone density tends to go back to where it was. Okay, you can prevent that, of course, if you follow with denosumab. But then you're back in the problem of what to do if you want to discontinue the medication. So it's kind of going in circles here. So one potential solution is to follow with an oral bisphosphonate for 1 year. This small study from a Japanese group shows that transitioning from the romosozumab to ibandronate is probably not as efficacious as if you switch to denosumab, but certainly is able to maintain bone density quite well. So I think it's easier. There are better ways of romosozumab than there are with denosumab. Finally, I just want to point out that if we think about sequential treatment, the type of sequence is very important. Okay, so here this is a busy slide. I'm sorry. It's a great paper, review paper by Felicia Kosman. But essentially, what it's trying to say is that if you start with romosozumab, before you give either alendronate or denosumab, you get the largest changes in bone density, 15%. But if you do the reverse cycle, if you start first in a resorption inhibitor, alendronate or denosumab, and then you switch to romosozumab, you don't get as much bang for the buck, okay? And this is also, after 2 years of monitoring. So the sequence is important. Start with an anabolic agent first, if you can, and then transition to a resorption inhibitor. This is now far more important for short-term anabolic treatments like romosozumab than it was in the past. So, and this essentially summarizes that. So treatment sequence is important. An anabolic agent for 1 to 2 years followed by anti-resorptive achieves the largest gains. Previous exposure to anti-resorptive agents can reduce the effectiveness for anabolic agents. Combination may yield the largest gains, but the advantages may not justify the cost and the nuisance to the patient. So during this presentation, 342 people have had a fragility fracture, even if you didn't notice. 60 people have broken a hip, and we knew that 30 of them were going to break a hip. So we have the means to prevent this to have happening. We need to use them. And unfortunately, one of the challenges right now is patient acceptance of effective treatment that are there and can be used. So one take-home message that I would like to give you, to leave you with, is talk to your patients, explain to them what's the risk of what's in having a fracture, okay, and how important it is to prevent it. Thank you so much for your attention.
Thank you for that very didactic lecture, informative and very useful for those of us that take care of patients with osteoporosis every day. This is really important. We're at the top of the hour, so I want to thank everybody for coming. And please check the chat and the QR code on your way out for the CME and MOC. I'd like to thank our sponsors for today's Grand Rounds. And if I could just ask you one quick question. The data that you show us is the efficacy in women. Is there any nuance in men?
Yeah, there are studies in men for many of these products. For example, bisphosphonates are approved for men. Denosumab is approved also for men, although primarily for men with castrate-resistant prostate cancer on androgen deprivation therapy. The PTH analogs are also approved for men. Not so romosozumab yet. There is a man study that was conducted, was very positive, but for some reason, for a link to fear of side effects, have not been followed up with full FDA indication. So,
Thank you.
but there is a lot of nuances with men as well. So,
Thank you, everybody.